Hello, everyone. Thank you for calling in today and joining us for our Cenegenics webinar on understanding your personal health biomarkers. My name is Rudy Inaba. I'm the Global Director of Nutrition and Exercise for Cenegenics, and I'll be taking you through a couple different biomarkers today that you can start to look at with your physician and develop an action plan to age well. So number one is, how do we define health and healthy lifestyles on a daily basis? And when I say we, I mean, how do we as a general population look at health and healthy lifestyles? And if you ask anyone, whether it be a friend or a family member or someone you know from the gym or someone you see on a regular basis, many people will commonly say that there are many healthy lifestyle components such as nutrition, exercise, consuming fruits and vegetables, managing stress levels. More people are talking about meditation now these days. Sleeping is also getting more mainstream, having a good sleep for recovery and also stress management. And also health is someone who's kind of far away from preventable diseases, someone who's essentially on the opposite end of the spectrum when it comes to risk factors associated with disease and aging. And that's a very common thing. We ask anyone that, those are the common answers we're going to get. However, when we look into medicine and we look to see how clinicians are taught and how they view health, that health is essentially the absence of illness. So meaning that we can fall anywhere on a spectrum of what's considered normal. And until we cross over into those red lines and those outside parameters, we are now considered diseased or sick. So anywhere before that is considered healthy. So that is somewhat of a little bit of a disconnect as far as being a patient and feeling that you're healthy, you don't have any illness, and then all of a sudden, 6 months later or a year later, you go for another checkup, and all of a sudden now you have types of preventable diseases. So again, there's a large personal disconnect. Many people know how to improve their health. If you ask a number of people of what they can do and how they can improve their health and longevity over time, they'll have many ideas of what they could accomplish. However, when you talk to the same people, they might not have implemented any of these strategies or components into their lifestyles to have success long term. And many people do also consider that having health being simply the absence of illness isn't necessarily the best definition. We kind of hold ourselves to a higher standards and higher accountability. However, yet many people from a day-to-day basis and annually, we start to see higher amounts of disease as someone goes on to see their physicians for their general checkups. So ultimately, we really start to understand that there's a level of awareness. And initially when we're not paying too much attention to it, it's common for us to compare ourselves to others, people in our environment. So if there's someone we see at the gym or someone at the grocery store, or even family members that we see on a regular basis, we're always kind of comparing our health levels to them and seeing on where we fall within our spectrum. If we are, much better as far as, keeping our weight managed than some other people, or if we're consuming better foods than others, we start to feel like we have a little bit of an edge on our health and we're living a healthier lifestyle. We also take that a step further and we start to compare ourselves to those that are within our closer circle. Someone within the household, we compare ourselves there. But really, the best potential case for someone to really follow a strong exercise, nutrition, and lifestyle program is when they are looking at their own personal numbers and starting to understand their own individual risk factors and what kind of symptoms they're having. When we start to do that, we start to engage a new level of awareness that are going to be beneficial for someone to intrinsically become motivated and see those positive changes long term. So unfortunately, the common wake up moment is when someone goes in for a general checkup, or maybe they're not feeling too well or they're sick, they go to their doctor. And the first thing they're going to do is get some blood work done, do a systems check, and essentially see what's going on. And for many people, unfortunately, this is where we start to see, some strong levels that are outside of normal ranges. It could be things from type 2 diabetes to heart disease, to even more significant factors with cancer and other risk factors there. So really, in efforts to avoid this wake-up moment, we challenge our patients and also everyone listening today to take advantage of your health right now and go ahead and look into your lab work and speak with your physician to start to look at these numbers while you're a healthy person before they start to fall out of line and get out of range. So essentially, again, the leading component of this presentation is to take ownership of your own health. So by regularly measuring and collecting your information, you're going to understand a deeper perspective of your health and what's going on in your body. You start to see changes over time on how your body adjusts to different foods, different exercise programs, different strategies that you may be implementing. And you also start to see when maybe you start to fall off, typically around the holidays or coming towards the new year. We start to see some lab work of patients that are getting slightly out of range. And that first lab draw we do at the beginning of that following year, it's kind of like a kick in the pants to get someone started. So by tracking this on a regular basis, we're really going to be able to take the preventable measures to see the positive outcomes. So when I say biomarkers, so what are biomarkers? Biomarkers are a measurable indicator of some biological state or condition. It is used to evaluate and examine biological processes or pharmacologic responses to therapeutic intervention. So the goal of today's call is to look into these biomarkers and which biomarkers you can start to pay attention to and discuss with your physician. So the two types of biomarkers I'm going to look at today that we can find via a blood analysis and also a fitness assessment. So in a blood analysis, there's a number of things that we can look at. What we're going to look into today is a carbohydrate metabolism, your lipid profile, inflammatory markers, for men, your prostate health, and also a hormone profile. There's also fitness assessment biomarkers that we're going to look into that include cardiopulmonary health, body composition, and also bone mineral density. So the blood analysis, getting into it a little bit more, it is a serum blood draw. So for our patients, we have our phlebotomy network reach out to our patients, and our phlebotomists come to our patients' home or offices to draw their blood. If you are working with your primary care physician, typically there is a phlebotomy office in the hospital or in the medical offices that you're in. When we look at carbohydrate metabolism, we're going to be going into it next, but we're going to look at glucose, insulin, and hemoglobin A1C. We are going to be looking into lipid profiles and what they are measuring. As far as inflammatory markers go, we are going to look at high sensitivity C-reactive protein, or CRP for short. For prostate health, for serum markers for the blood analysis, we are looking at a PSA level, which is a prostate-specific antigen. And for a hormone profile, we are looking at testosterone in both total and free testosterone, DHT or dihydrotestosterone, estradiol, and IGF-1, which is a marker for your growth hormone. So for carbohydrate metabolism, as I mentioned, we are looking at fasting glucose, fasting insulin, and hemoglobin A1C. So glucose is our blood sugar, essentially. And when we're looking at a fasting, it's after we've been in a 12-hour fast and seeing where our blood sugar levels are without the presence or stimulus of food that we're ingesting. So if someone is on a fast, typically we see what their homeostatic glucose levels are. If someone were to eat or they were to drink alcohol or some kind of sugary drink, that will cause glucose levels to spike, and that could throw off our reading. Now, glucose and insulin work together as partners, essentially. Whenever we consume carbohydrates or even other foods, essentially they are going to be metabolized and go into as glucose, as blood sugar. And we can't have blood sugar just floating around our bloodstream for long periods of time. So our pancreas releases insulin, and insulin's role is then to draw the blood sugar and the glucose out of the bloodstream and shuttle it into the cells, either the muscle cell or the fat cells. So when we look at a fasting draw, we're looking to see glucose levels preferably in the lower range because food is not present, food isn't stimulating a glucose response. And we also want to see a low insulin response as there is no glucose present, so the pancreas shouldn't be releasing insulin. In the event that we see someone with poor insulin sensitivity or they're on the verge of poor insulin sensitivity, we'll commonly see either elevated levels of glucose in the bloodstream even during a fast, and also elevated levels of insulin in the bloodstream during a fast. Over time, this can start to increase the value of which is called your hemoglobin A1C. And hemoglobin A1C is a marker for glycation, and glycation is essentially the stickiness of the red blood cell. What happens over time, if you start to have elevated insulin levels and elevated glucose levels, the proteins can start to become sticky, and that causes our hemoglobin A1C levels to go up. And that is a strong marker for type 2 diabetes as we get older. So a marker, typically what we see as risk factors is above a 6.5 hemoglobin A1C. And for many of our patients, we keep that below around a 5.3 to a 5.5. So that is something we track, and that's directly related to our carbohydrate consumption. Another value that we look at are our lipid profiles. And the lipid profile includes your high density lipoprotein, which is your HDL, which is considered your good cholesterol, and also your low density lipoprotein, which is your LDL, and that's considered your bad cholesterol. We also look at triglycerides. Now, HDL is good because what it does, it absorbs cholesterol and it carries it back to the liver for the liver to then flush it from the body. So it'll actually pick up that cholesterol and remove it from the body. So a higher HDL level is what we want to see. LDL levels that are consistently elevated, that's when we can start to see significant risk factors develop year over year, decade over decade in patients for heart disease development. And triglycerides are essentially fat in our blood. So that's the fat in the blood. So when we start to consume foods, our triglycerides get in the bloodstream, and that can either be stored in the cells to either increase the size of the fat cell and have larger fat, but also in the same respect, if we are on a diet and we are losing fat levels and we're using fat as an energy source, fat is released from those fat cells in the form of triglycerides that are going to be going in the bloodstream. So in the same respect, if someone who is not following a strong nutrition program, who is gaining weight excessively, they're likely going to come back with higher triglyceride levels due to the foods that they're consuming. It's more present in the blood. But on the opposite side of that as well, if someone is aggressively trying to lose weight, they are exercising, they are training a lot in their aerobic zone, they're using fat as an energy source, typically we see triglyceride levels go up temporarily because that's their body's way of releasing those triglycerides from the fat cells. C-reactive protein is a very strong marker we also look at. I'm going to call it CRP for our conversation. It is a marker for inflammation. So you can look at it in a number of ways. When we look at CRP levels, it's very sensitive. So if someone has an infection or an acute injury, for example, say if I tore a bicep or I rolled my ankle, or for the infection if I'm sick, typically when we look at our C-reactive protein levels, because it's so sensitive marker for inflammation, our body is inflamed. And the inflammation process in that scenario is a good thing because it's going to start to heal the body. Acute inflammation in efforts to recover from something, that's a normal inflammatory process. However, when we see chronically elevated levels in the kind of just outside of normal ranges for our CRP, we know that we are now looking at chronic inflammation. And chronic inflammation is much different. When there is not an injury present, when there is not an infection present, if our body is just consistently inflamed at low levels, that's essentially a silent killer. And over time, if that's not treated and lifestyle changes aren't put into place, that's going to aggressively increase our risk factors for heart disease and also additional disease development. So for men, so prostate health. So again, going to blood analysis, we look at prostate-specific antigen, but we also do a physical exam on our patients. And most men over 40 should be going to see their physician for a prostate exam annually. But the PSA, so prostate-specific antigen, is actually a protein that's produced by both normal and malignant cells of the prostate. If we have elevated levels of PSA, then we are potentially, if we see it initially and it's stable, but it's a little bit higher levels, that's more of a sign for benign prostate hyperplasia, so an enlarged prostate. In the short term, if it goes up a little bit, if it comes back down, that's more inflammation of the prostate or prostatitis. If there is an aggressive increase lab over lab, so one quarter over the next or month over month, however frequently we're looking at our PSA level, that can be a strong indicator for potential prostate cancer. So at Cenegenics, we preemptively look at PSA levels on all of our blood draws for our patients to track these risk factors as we go along in the program. So the hormone panel. So hormone panel is a big one that is very interesting for a lot of patients and also a lot of people engaging in an exercise program and a nutrition program. The big ones we look at are total testosterone, free testosterone, dihydrotestosterone, which is DHT, estradiol, and also IGF-1. IGF-1 is a little bit different. It's in its own section because it's more along the lines of growth hormone production. So growth hormone production, it has a pulsatile response in nature. So when we wake up in the morning after our adrenaline levels spike and we get hungry, typically we have a pulse of growth hormone. When we go into our REM sleep cycles, we also have pulses of growth hormone. So it's a pulsatile fashion. IGF-1 is a marker that kind of gives us an idea of how strong those pulses are throughout the course of the day. It's kind of like almost like a homeostatic representation of our growth hormone levels. When we look at the next ones with the total free testosterone, dihydrotestosterone, and estradiol, they all are, they're interesting because they kind of work together. Think of it almost as far as like a pyramid where total testosterone is at the top. And from that pyramid, we could go down into one section being free testosterone, another section being dihydrotestosterone, and another section being estradiol. All three of them are important. Estradiol is commonly looked at and viewed as a female hormone. However, estradiol is very important for men and women for bone health, libido. It's just that those levels of estradiol can't necessarily get out of range. If they become too elevated or testosterone is converting too aggressively into estradiol, many patients can find issues with gynecomastia development. They could find other sensitivities. They could start to feel maybe anxiety or depression. Symptoms are different from patient to patient, but there are potential risk factors if estradiol levels are getting outside of normal range. We don't want to plummet them and crash them into very low levels, but we also don't want to have them go too high. So there is a sweet spot. The same goes for DHT or dihydrotestosterone. Total testosterone can channel into DHT, and if DHT gets out of range and it goes too high, that can be a potential issue because it can increase risk factors for male pattern baldness and also for benign prostate hyperplasia. So it can be an enlarged prostate issue. So DHT, although it is a very good hormone, and that's something that can aid with libido and strength and some of the more classically defined masculine traits of testosterone, if it's going too far out of range, there can be some issues that need to be controlled. And lastly, free testosterone, that's a big one to look at because that is our bioavailable testosterone. That's the testosterone that we're going to be more able to use for recovery, for strength, for energy levels. Everything that we start to read or that you'll see in advertisements about testosterone being a strong key to vitality for men's health and women's health. When we dig into it a little bit more, it's considered the free testosterone. That's the most important thing. So moving on from the blood analysis of some biomarkers that you can look at, we're going to look at some fitness biomarkers. So the biomarkers we're going to look at for fitness today are for your cardiopulmonary health, body composition, and also bone mineral density. So for cardiopulmonary health, the way that we measure this in all of our Cenegenics centers across the country and also internationally is VO2 max testing. VO2 max testing is strongly performed in academic scenarios with college-age students, so 18 to 35 years old. It is a maximal effort cardiovascular test. However, we implement that into all of our centers for our patients, working with patients anywhere from 35 to 65 years old or older. For body composition, we do look at, we measure everything through a DEXA scan, which is DEXA scan stands for dual energy X-ray absorptometry. It is very testy and tester friendly, and also as far as accuracy goes, it is strongly in line with underwater weighing, bod-pod analysis, and it is more convenient for our patients to use as well. Bone mineral density is also done via DEXA scan, so dual energy X-ray absorptometry. And when we look at bone mineral density, we're looking at a 4-sequence scan, which entails the lumbar spine, so lumbar disc or lumbar vertebrae 1, 2, 3, and 4. We look at the neck of the femur and the hips, and also a total body scan. So for cardiopulmonary health, essentially when we say cardiopulmonary health or cardiopulmonary efficiency, it's how well the heart, lungs, and your muscles, your skeletal muscles, work together during exercise. It's almost like a peak oxygen consumption. So we perform all of our tests on a bike due to our patient population. Classically in a university setting, the test is done on a treadmill. However, with a treadmill VO2 max test, we are increasing speed and also increasing the grade of the treadmill, similar to a Bruce protocol. So it is a maximal effort test. So once we take the testee to a peak level of exercise, we need to stop the test. And on a treadmill, typically those belts take somewhat of time to slow down and bring down the incline. So for someone who hasn't exercised in maybe a couple of years or a couple of decades, working up to a peak level of exercise and trying to sustain that while that machine is slowing down can be a potential issue for injury. In undergraduate and graduate school in the physiology labs, we actually were prepared to catch people when they would fall off the treadmill. On a bike test, the bike is far more, it's a much safer environment as we increase the resistance via the wattage on the bike. And every minute the wattage goes up, our patients start to push harder on the bike, so it's increasing the intensity that way. The nice thing is that when our patients reach maximal intensity, or if anyone were to do a VO2 max test on a bike and they reach maximal intensity, we can actually just stop all the wattage on the bike, and then you can pedal against a free resistance on the pedals. So it's much safer in that recovery zone. So there's a number of values that we can look at. When we look at heart health, there are things that we classically look at, like peak heart rate achieved. Typically, when someone looks at their maximum heart rate, you can do 220 minus your age. That's a age predicted maximum heart rate. However, there's about 30% variability within that. So doing a VO2 max test will allow you to see your actual peak heart rate achieved. We look at heart rate recovery. When you look at heart rate recovery, a normal recovery from peak level of exercise is roughly a reduction in 12 beats per minute. Many of our patients come in around that 10 to 12 beats per minute before they start an exercise program. And really in as early as 6 weeks, even 8 weeks, we'll start to see recovery heart rates increase more to like 18 to even 24 beat per minute drops. So they recover very quickly from exercise, and that is a strong indicator of cardiovascular health. Oxygen pulse is another one, and it's essentially how much oxygen we are pumping via our bloodstream every beat of our heart. So as that increases, our risk factors for heart disease also go down. As we call it cardiopulmonary health, we're also looking at the pulmonary system, so the lungs. So as far as VO2 max and lungs go, we can look at tidal volume, which is how large your lungs can expand and how much air you can fill into your lungs. We look at respiratory rate, which is how many breaths per minute you can make, so filling your lungs and also exhaling and repeating that as frequently as possible. And when we take tidal volume and we look at respiratory rate, we combine those two, and that gives us minute ventilation. So for lung health, cardiovascular health, there are a lot of standards that are implemented for both men and women. There's a lot of norm charts from a lot of different organizations. However, we found that pulmonary health, what's healthy for a petite woman who's maybe 5 feet tall versus a 6'3" male are significantly different. Obviously, the anatomy is different. Lungs can fill to a different capacity. Someone who's trained is going to be having a higher respiratory rate, so that can significantly alter the minute ventilation scores. So while we do have norm charts for that, we also personalize that to see what the anatomical characteristics are of the patient. So body composition. So in here is an image from a DEXA scan analysis. So we look at 3 different things for our patients. We can look at many different things, but the 3 that we typically look at and that you can look at for managing your health and your risk factors are your total body fat percentage, your trunk fat percentage, and your visceral fat percentage. So total body fat is as simple as it sounds. It's the total percentage of fat you're carrying on your body. For men, anything considered, anything under 20% total body fat is considered normal. And for women, anything under 25% is considered normal. When we look into trunk fat, that's looking at the torso of the body. So if you see, if you can look at the image there, you see the torso, that box, and also an upside down triangle. That's kind of like right where the hips are. That's the trunk fat. So trunk fat is isolating what's around that torso. It's a good measure for potentially what's in the abdominal cavity. We actually take it a step further and also look at visceral fat. And the visceral fat reading is not just the entire torso, it's actually right around the waistline. So it allows us to see what's around the internal organs. So essentially for patients, or if you're interested in a weight loss program or engaging in a healthier lifestyle and you want to find out your body fat levels, first finding out what your total body fat percentage is and focusing on improving that will be step 1. From there, as you start to achieve sub 20%, sub 25% levels of body fat, then focus on getting trunk fat underneath 20%. And as that is then achieved, focus on getting visceral fat under 20%. The visceral fat is the much higher risk factor that's associated with preventable diseases, things like cancer, metabolic syndrome, diabetes, and heart disease. For bone mineral density, as I mentioned, we look at total body bone density, lumbar spine, and also the neck of the femur or the hips. So for bone density, we don't simply just look at total body because there are weak points essentially. When we look at the aging process and when we see fractures and breaks that have significant poor outcomes in patients that are older than 70, typically when someone falls or has a break, we see it in the lower back or the hip. And the image you see on the left-hand side, we isolate lumbar spine 1, 2, 3, and 4, where you see the floating rib crossing is thoracic vertebrae 12. So this is a weaker point of the body. So if we isolate the lumbar spine and the hips, and if we see low levels of bone density that are osteoporosis or osteopenia, we know that over time, if nothing is implemented or no treatment is implemented, that the entire body can then start to see those risk factors. For the hip, we look at the neck of the femur. So if you see the femoral neck right there where that rectangle is laying over, typically if someone has a break, it's going to be right around that area. So we do measure the bone density of that area as well. So again, going back, if we were to look simply at total body bone density, if someone had a normal range score there, that is excellent. However, if we did not look at a lumbar spine or a hip and those levels were poor, maybe that patient could start to see risk factors of the total body levels going down within the next 5 to 10 years. One other thing I would like to say about bone mineral density is that typically in a hospital setting, mostly women are only getting bone mineral density scans done. And commonly they're only done every other year because it does take time for bone density to change. In our locations and in our centers, we actually measure total body bone density, lumbar spine bone density, and femur neck bone density annually. And we do see, for both men and women, and we do see significant changes due to the treatments that we put in place. So next steps. So now that you know what health biomarkers that you can look at, what are you going to do with them? So the biggest thing is acknowledge which ones are out of range, as well as which ones are good. It's almost, it's tough sometimes to look at markers that are out of range when you may have thought that you were a healthy person, didn't have a lot of risk factors. Now all of a sudden there are, X, Y, and Z things that we want to improve. So recognize the things that are at range, look at it almost from an analytical standpoint, recognize the things that are good, and then look to see which things are the most immediate risk factors that can be improved upon. And then develop a suitable action plan. You want to address the priority items first, ones that are going to yield positive outcomes directly, and that can also yield secondary outcomes that are good. And that plan needs to be suitable and progressive and sustainable long-term. So the positive data. So again, looking at what's going right and what components contribute to them. So for example, if your blood sugar levels are great, your insulin sensitivity is great, your hemoglobin A1C levels are low, that's good. Your carbohydrate metabolism is good. If your body fat levels are also correlating with, their low acceptable ranges, your carbohydrate management is relative to your energy expenditure, you're doing really well there. So you need to recognize that and not focus on adjusting some of those things if those are correct biomarkers. Focus on the things that are out of range. So when you look at the things that are out of range, what are the key contributors? Which things are the easiest to change? And what are the long-term goals there? So with these, again, prioritizing red flags. So on the flip side, if someone doesn't have good carbohydrate metabolism and they have poor insulin sensitivity or glucose intolerance, someone who has, if that's a scenario, short-term restriction of carbohydrates could potentially be beneficial for a lot of patients. For our patients, when someone does present with poor insulin sensitivity and glucose intolerance, we do strictly remove the strong presence of carbohydrates in their diet and focus more on fruits and vegetables as their primary sources. And then as we start to see those levels improving and changing, then we start to include carbohydrates back into the diet, especially as exercise starts to ramp up. Someone with poor HDL levels, Having poor HDL, many times someone will think, okay, well, if it's associated with fats, maybe I'll start to eat better, healthier fats, eat less packaged foods, which are all great. That's going to help improve LDL cholesterol. It's going to help improve triglyceride levels. But HDL, from my experience and from the literature, it's going to have best improvement by implementing an exercise program that's going to include more intense exercise. It sounds daunting. However, intense exercise isn't exercise that needs to be sustained for long periods of time. It doesn't need to be done excessively. If something is intense, the relativity to that is that it needs to be, brief, and then your frequency can depend on your fitness level. So by implementing anaerobic training or metabolic conditioning, that can help increase your HDL. Chronically elevated inflammation. Inflammation can come from a number of things, and most people it's related to diet and some other environmental factors and other potential things with stress. So all of those things can be included. Stress management, focusing on removing inflammatory foods, so things that are packaged, things that maybe doing a food and allergy and sensitivity test could be beneficial, as there are foods that are generally inflammatory, but there are also foods that are individually inflammatory. So by looking a little bit deeper, you can have a better perspective or a better lens of what's going on with your body when you eat certain foods. Poor hormone production with correlating symptoms. So there's a number of things you can do. Obviously, on Cenegenics Elite Health Evaluation, working with our physicians, one of the pillars of what we do is hormone optimization when it's clinically indicated. However, that doesn't mean that for someone who is not seeing a physician that there aren't things that they can improve on to help increase their hormone production. In my opinion, the easiest thing would be sleep. Studies show that if you're sleeping less than 6 hours per night, you can see anywhere from a 10 to 30% drop in your testosterone levels within the first week. So sleep is very significant for hormone production. In addition to that, managing your insulin sensitivity over time can start to also improve your hormone production and insulin production as well. Cardiopulmonary function, again, that goes back to an exercise program, working up into that metabolic conditioning, anaerobic levels of intensity range, and high visceral fat, trunk fat, total body fat, all the things we talked about. Exercise, the carbohydrate restriction for short term until levels manage out, and also sleep can all help with all of these. So again, when you develop an action plan, the action plan needs to be individualized. You can find plans online, you can find 12-week plans or 8-week plans or 3-week plans. They're all out there. But for long-term success, an individualized action plan is more suitable, something that fits your lifestyle. For someone who maybe works different shift times, or someone who has multiple children and school times and family things that are going on, we need to be realistic, and the things that we can change are things that we cannot with our schedules. So by working with a professional team or someone who's working with patients from this level, there's a strategy in seeing how we can implement an effective program around all lifestyles. Again, we want to address the urgent items first, essentially like low-hanging fruit, things that are going to, we want to implement things that are going to have the most benefit with really the least amount of resistance in someone's lifestyle. And we want to progress those. As we start to cross off that low-hanging fruit, we want to take up the intensity to the next level, see what next thing we can change, and have a progressive plan. One of the big caveats to exercise is that it's a stimulus that forces an adaptation. And as our body adapts, we need a new stimulus. So that's why a lot of times in March, you see the rush of new gym members come in January, and then by March, April, it starts to go back to normal. Many of those people saw great significant results right off the bat, but they fell victim to not changing their program and making that same program hard again. We need to continue to challenge ourselves to see efforts going in the right direction, to push ourselves in the low end of the risk factor spectrum. So how can you put this into practice? So as I mentioned, find the things that are essentially the low-hanging fruit that are going to give you the most bang for your buck. In many cases, carbohydrate management, alcohol management, stress management, high-intensity exercise, those can do a significant amount for your health and longevity. And when it comes to the potential hormone optimization, that's when a physician can come into place as well as a professional team. So at Cenegenics, we evaluate significant collection of biomarkers. Our elite health evaluation is roughly 6 to 7 hours in length. Initially, before someone even comes in, we do a personal assessment and family history based on a self-report. We'll also look at a blood analysis where, again, we have our phlebotomists go to our patient's home or office and do a blood draw of roughly around 100 different values. We look at additional lab data in our specialty programs. Programs can range from telomere programs to the food allergy and sensitivity that I mentioned, micronutrient deficiency testing, and also genomic testing. When our patients are in office, we do our diagnostic assessment and also fitness assessment. We do a cognitive test for our patients as well. And we determine our patients' readiness to engage in positive lifestyle changes. Obviously, from the position where we stand, we want to, push the most ideal program possible. However, in most patients' lifestyles, the best option that we can put on paper isn't necessarily the most practical or realistic for them to sustain. So that relationship allows us to work together to find what's the most appropriate that's going to yield the best response for them. Our Cenegenics physicians, they are certified and trained in age management medicine. Cenegenics, we have our nonprofit arm where we train physicians in the field of age management medicine as a medically accredited program. All of our physicians have practiced in a variety of medical fields throughout their career. They all take a proactive approach to managing disease as well as risk factors. They all walk the walk, so to speak. And they review patients comprehensively in efforts to treat them comprehensively. We don't do a kind of Band-Aid, or we don't just treat symptoms. We want to see what symptoms our patients are experiencing, looking at their lifestyle, looking at things they've gone through, and kind of determine what the critical factors are that are causing this. And we want to change those factors via their lifestyle as well as their hormone optimization. So I want to thank everyone. Again, that was our review of different biomarkers that we can look at. And if you have any questions, please feel free to contact us via email, call in, and we can answer any of those questions for you regarding biomarkers, also Cenegenics programs.
Hi, everyone. Those of you out there that may have a question, down in the lower right-hand corner of your display there, you'll see a button that says chat. Go ahead and click that. It's going to change over to ask a question, and that'll make sure our questions get addressed. Rudy, do you want to?
Yep. So we have a question that asks, how do you take into account any pre-existing injuries when implementing Cenegenics exercise programs? Fortunately, on a Cenegenics program, when someone comes in, we are with them for 6 to 7 hours in length and sometimes more. So we are able to look at their exercise history, their injury history, and determine what exercises and what kind of movement patterns are both beneficial and potentially risky for them. During our fitness assessment, we do a movement analysis of our patients where we look to see what movement patterns are weak, which ones are strong, which ones could potentially yield an injury. And we will adjust exercise programs accordingly based on the individual. Again, going outside of just the standard, 8-week program or 12-week program, we look to see what our patients' goals are, what their exercise history is, what their injury history is, and what kind of movements we can implement to yield the results that they're looking for. Another question that we have is, how often does Cenegenics check the biomarkers discussed? That is an excellent question. So we look at our baseline biomarkers. So prior to anyone coming into our office, we will look at that full comprehensive panel of our patients. And then as they come in and they start treatment, we commonly do a potentially 6 to 8 week follow-up labs of all of those different values, and then some more than actually what I discussed today. And as we start to see those markers get into the correct ranges we're looking for, we move to quarterly lab draws, again, looking at all those levels. It's my understanding that many programs will look at certain isolated values, and they will commonly not do them as frequently. So we're actually looking at those 100 different values at baseline, the first 6 to 8 weeks after treatment, and then quarterly afterwards. If there are things that start to fall out of range that we need to repeat, we'll actually go ahead and do that preemptively. Again, because the labs show us a lot, biomarkers show us a lot, so we want to stay on top of that. So another question we have is, how do you address nutrition when people have serious time constraints that may not allow them to prep ahead of time? So Our patients are commonly busy executives, business owners. Actually, 25% of our patients are physicians and their families. So, a lot of times when someone learns about the main components of what we do, whether it be nutrition, nutraceuticals, exercise, hormone optimization, they think that most people that just step foot into the program are, very, weekend warriors or strong exercisers. That's really, not the case all the time. I mean, we have people with busy schedules across the board. Really, we start to see what our priorities are and which things are the things that we can't really, that we need to put as our priority items. Commonly, it's our protein consumption, making sure that someone is commonly eating enough protein for their lean body mass that we found in the DEXA scan. A lot of times it's focusing on restricting some of the more dense carbohydrates. Really, if someone doesn't have the time to do a whole lot of exercise and they have a lot of body fat on them, their carbohydrates should be reflective of that. So if someone's not exercising, they have excess fat levels, the carbohydrate consumption should really be focused on fruits and vegetables and consume that around whenever they can, whether it be breakfast, lunch, dinner, or even snacks in between. So really, during our evaluation, we have that time with our patients to sit down and see what we can accomplish throughout their day-to-day basis for what we can implement nutritionally and also exercise-wise. Another question we have is, will the program help to determine any food sensitivities or allergies? Yes, we have our advanced labs that we look at food allergy sensitivity testing, as well as micronutrient deficiency testing. So when we look at those, really right off the bat, what we do for a lot of our patients is we start to implement, more fruits and vegetables, more lean proteins from preferred sources, healthy fats. And if over time we start to see some inflammatory numbers still not really improving or just not improving at the rate that we would expect them to, that's something we will look in further. However, if we have more advanced patients that are really interested right off the bat to see which foods are potentially causing allergies or even a sensitivity response, we'll actually do those labs right away. Another question is, are there any common physical indicators to tell if chronic inflammation is a possible issue to address? Unfortunately, we call chronic inflammation the silent killer for a reason. Really, in many cases, for some of the younger skewed individuals that we see, whether they be in their mid to late 30s to even 40s, if they've had chronic inflammation for some time, unless we're looking at that CRP level, we might not have seen, dramatically, blown up blood pressure levels or significantly increased cholesterol levels. What we'll do is during our evaluations, we look at a carotid intermedial thickness scan, which is an ultrasound of the carotid artery of the neck. If someone does have chronic inflammation, that intima media, that inner layer of the artery could actually be inflamed. We can catch that on the ultrasound. But we will absolutely see it in labs. However, if there's something, if you just feel, it's a hard thing to feel as far as chronic inflammation because it is low-grade chronic inflammation. It's not a spike. It's not like the redness around a scratch or a cut that's healing. It's a very low-grade inflammatory response. So really looking at your labs is the best thing that you can do. If I'm already using a different hormone therapy program, can I still benefit from the program? Absolutely. Really, everything that we do takes a comprehensive approach. If you were to be on a hormone program, specifically maybe like testosterone, I've seen them, being in Las Vegas, I've seen them in many places. Some are great, and other ones are potentially really minimal a la carte types of programs where they'll only look at a total testosterone level, which I mentioned. Total testosterone can funnel into free testosterone, to DHT, to estradiol. All of these things can change based on your total testosterone. So if a physician or a practice is really only looking at that total level and then prescribing bioidentical hormones and then not following up on that on a repeated basis until maybe the next year, your total testosterone could shoot up, which could then channel into the wrong components. Maybe it will spike up DHT, it could spike up estradiol levels, and because you're not preemptively or having the next lab scheduled, you could be dealing with some symptoms that you didn't expect. However, when you're doing a comprehensive program where we're looking at these values all the time, we know that if you are placed on bioidentical hormones, if it's clinically indicated, and we see your total testosterone rise, and we see the free testosterone rise, but maybe the DHT is too much or the estradiol is too much, we can then start to recover that and get on an appropriate program and make those fine-tuned adjustments that really you're only going to be able to know and understand by looking at these biomarkers frequently. All right, guys, so that's all the questions we have time for today. But again, if you enjoyed the presentation, please feel free to call in, let our team know. If there's any other biomarkers you'd like us to look into in the future, I'm happy to discuss. And thank you all again for attending.